All right, now you can start.
All right. Hi, everyone. My name is Aruj, and I will be presenting along with Amani and Nicholas. And our topic for today is mental health. And before we begin, we would just like to start off with mentioning a trigger warning, as we will be discussing sensitive topics such as mental health disorders and suicide. So we want to start off with Mental Health 101 and what is mental health and why it's important to us. Mental health is a state of well-being in which an individual realizes his or own abilities, can cope with normal stresses of life, can work productively, and is able to make a contribution to his or her community, as stated by the World Health Organization. Mental well-being includes emotional, psychological, and social well-being. Mental health disorders. A mental health or psychotic disorder is a mental illness diagnosed by a mental health professional that greatly disturbs your thinking, moods, and or behavior and seriously increases your risk of disability, pain, death, or loss of freedom. Some of the main psychiatric disorders include depression, personality disorders, anxiety disorders, schizophrenia, eating disorders, and addictive behaviors. About 1 in 4 people will develop one or more of these disorders worldwide. Why it's important to us is because 1 in 5 US adults experience mental illness each year. 1 in 20 US adults experience serious mental illness each year. 1 in 6 US youth aged 6 to 17 experience a mental health disorder each year, and 50% of all lifetime mental illness begins by the age of 14, and 75% of it begins by the age of 24. Factors that contribute to mental health disorders. Mental health disorders can be caused by a variety of factors, either physiological, environmental, or cultural, that fluctuate on a person-by-person basis. Some examples of factors that contribute to mental health disorders are trauma, which include childhood trauma, abuse, neglect, domestic violence; physiological, which include injuries, genetic predisposition, neurological condition; and lifestyle, which includes work, diet, drugs, lack of sleep, and living conditions. So the first mental health disorder that we want to talk about is going to be depression. Depression, or a major depressive disorder, is a common and serious medical illness that negatively affects how you feel, the way you think, and how you act. It causes feelings of sadness and loss of interest in activities you once enjoyed. Symptoms of depression include feeling sad or anxious often or all the time, not wanting to do activities that used to be fun, feeling irritable, easily frustrated or restless, having trouble falling asleep or staying asleep, waking up too early or sleeping too much, eating more or less than usual or having no appetite, experiencing aches, pains, headaches, or stomach problems that do not improve with treatment, having trouble concentrating, remembering details, or making decisions, feeling tired even after sleeping well, feeling guilty, worthless, or helpless, and thinking about suicide or hurting yourself. There's 2 main types of depression. There's major depressive disorder or depressive episode, which involves symptoms such as depressive mood, loss of interest and enjoyment, and decreased energy. And depending on the number and severity of symptoms, a depressive episode can be categorized as mild, moderate, or severe. And there's dysthymia, a persistent or chronic form of mild depression. The symptoms of dysthymia are similar to depressive disorder, but tend to be less intense and last longer. So going into global prevalence of depression by the World Health Organization region, this is just a graph that shows what the population of the world looks like and how many are diagnosed with depression across the world. So according to the World Health Organization, about 3.8% of the world population suffers from depression, which is self-reported, and about 280 million have been clinically diagnosed with depression. about 5.5% of adults suffer from depression worldwide. And then annual prevalence among the US adults by condition is 8.4%, 21 million. And here we see the global, and here we see the global prevalence of depression by region and sex. So we see the African region, Eastern Mediterranean, European region of the Americas, Southeast Asia, Western Pacific, and worldwide. And we can see it from both the female and male. And here we see global prevalence of depression by sex and age. And as you can see, females are more likely to experience depression than males. Some studies show that 1/3 of women will experience a major depressive disorder in their lifetime. The next disorder that we'll talk about is bipolar disorder. Bipolar disorder, formerly known as manic depression, is a mental health condition that causes extreme mood swings that include emotional highs, mania or hypomania, and lows, depression that may occur rarely or multiple times a year. Bipolar depression is the least treated psychiatric disorder globally and is often misdiagnosed, especially on initial presentation. Since this disease contributes to suicide rate, there are areas of improvement for treatment of bipolar disorder. Some symptoms include mania, where one may feel euphoric, full of energy, or usually irritable; depression, feeling of sadness or hopelessness and loss of interest or pleasure in most activities; and mood swings that can affect sleep, energy, activity, judgment, behavior, and the ability to think clearly. And here are some stats on bipolar disorder, in a graph showing bipolar disorder per 100,000 by the World Bank. It is the least treated psychiatric disorder globally. Since this contributes to suicide rate, there, as mentioned earlier, there are areas of improvement to further stratify bipolar disorder. We take note in the presence of manic episodes. Bipolar type 1 is a combination of depression and manic episodes, while bipolar type 2 consists of more depression episodes with mania, often not as severe, better known as hypomania. About 4% of people in the United States experience bipolar disorder at some point in their lives, according to the National Institute of Mental Health, and an estimated of 2.8% adults had the disorder in the past year. Next, we'll be going into schizophrenia. Schizophrenia is the mental disorder in which people interpret reality abnormally and may result in some combination of hallucinations, delusions, and extremely disordered thinking and behavior. This disorder can impair daily functioning and can be disabling. Some risk factors include genetics, environment, brain structure, and function. Schizophrenia is characterized by distortions in thinking, perception, emotions, language, sense of self, and behavior. Common experiences include hallucinations, hearing voices, or seeing things that are not there, and delusions such as fixed and false beliefs. Symptoms include hallucination, hearing or seeing or feeling things that are not there, and delusions, as mentioned earlier. Another symptom is abnormal behavior, disorganized behavior, such as wandering aimlessly, mumbling, or laughing to self, strange appearance, self-neglect or appearing unkempt, disorganized speech, incoherent or irrelevant speech, and or disturbances of emotions, marked apathy or disconnect between reported emotion and what is observed, such as facial expression or body language. Over here, this is from the World Health Organization, and this shows a map worldwide of number of people with schizophrenia in 2017. The darker shades show the higher rates of people with schizophrenia, and as we can see, United States, South and East Asia are one of them, a few of them. Schizophrenia affects 20 million people worldwide. People with schizophrenia are 2 to more 2 to 3 times more likely to die early than the general population. And this is often due to preventable physical diseases such as cardiovascular disease, metabolic disease, and infections. More commonly, the incidence of new cases of schizophrenia increases in the teen years, reaching a peak of vulnerability between the ages of 16 and 25 years. Men and women show different patterns of susceptibility for developing schizophrenic symptoms. Males reach a single peak of vulnerability for developing schizophrenia between the ages of 18 and 25 years. In contrast, female vulnerability peaks twice, first between 25 and 30 years, and then again around 40 years of age. Next, we'll go into dementia. Dementia is not a specific disease, but it's a rather general term for the impaired ability to remember, think, or make decisions that interfere with doing everyday activities. Because dementia is a general term, its symptoms can vary widely from person to person. People with dementia may have problems with memory, attention, communication, reasoning, judgment, and problem solving, visual perception beyond typical age-related changes in vision. Signs that may point to dementia include getting lost in familiar neighborhood, using unusual words to refer to familiar objects, forgetting the name of a close family friend or member, forgetting old memories, not being able to complete that task independently. And some risk factors for dementia include age, family history, race and ethnicity, poor heart health, and traumatic brain injury. And here are some stats for people living with dementia around the world. And this shows each region, and it shows 2005, 2030, and then the expected rates in 2050. Of those at least 65 years of age, there's an estimated 5 million adults with dementia in 2015 and projected to be nearly 14 million by 2060. Currently, more than 55 million people live with dementia worldwide, and there are nearly 10 million new cases every year. Alzheimer's disease is the most common form of dementia and may contribute to 60 to 70% of cases. And it is currently the 7th leading cause of death among all diseases and one of the major causes of disability and dependency among older people globally. Lastly, we'll be discussing suicide. Although there is a link between mental health disorders and suicide, many suicide attempts happen impulsively. Experiencing conflict, disaster, violence, abuse, or loss, and a sense of isolation are strongly associated with suicidal behavior. Suicide rates are also high amongst vulnerable groups who experience discrimination, such as refugees and migrants, Indigenous peoples, lesbian, gay, bisexual, transgender, intersex persons, and prisoners. The strongest risk factor for suicide is a previous suicide attempt. And just some stats on suicide prevalence worldwide. We see age standard suicide rates per 100,000 population, both sexes, and this was based in 2016. In 2015, 800,000 suicides were documented worldwide, accounting for 1.4% of premature deaths worldwide. And globally, 78% of those occurred in low and middle income countries. More than 700,000 people die due to suicide every year, and suicide is a 77% of global suicides occur in low and middle income countries. And then suicide as an indicator for service development. The World Health Organization mentions suicide prevention under its 3rd Sustainable Development Goal in the 17-goal list of global health issues to address by 2030. This SDG is identified as a Tier 1 classification due to the level of methodological development and availability of data at the global level. Suicide is measured as a number of deaths directly resulting from self-harm per year. It is paramount that we divert our efforts to this increasing problem, as suicide is now the 2nd leading cause of death globally among young adults. And suicide rates have increased 33% between 1999 and 2019.
Hi everyone, I'm Imani and I will go over mental health promotion versus mental health prevention. So, the distinction between mental health promotion and prevention lies in their targeted outcomes. Mental health promotion aims to promote positive mental health by increasing psychological well being, competence, and resilience, and by creating supportive living conditions and environments. Mental disorder prevention has at its target the reduction of symptoms and ultimately of mental disorders as a whole. It uses mental health promotion strategies as one of the means to meet these goals. The WHO has identified the prevention of mental disorders as a key priority. Preventative interventions focus on reducing risk factors and enhancing protective factors associated with mental disorders. Mental disorder prevention at its core aims at reducing incidence, prevalence, and recurrence of mental disorders, the time spent with symptoms, or the risk condition for a mental illness, preventing or delaying recurrences, as well as decreasing the impact of illnesses in the affected person, their families, and society as a whole. To treat mental disorders, historically, psychotherapy, hospitalization, case management, medication, including complementary and alternative medicine, as well as support groups and peer support, have been used. About 40% or more Americans self treat themselves with complementary and alternative medicines without supervision. However, some of these remedies also include taking prescription antidepressants. The controversial history of mental health in medicine includes sanitariums and asylums, transorbital lobotomy practice, as well as the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. Mental asylums were in widespread use in the 1800s. Those who were deemed clinically insane were sent to be treated in asylums where many atrocities took place, such as lobotomies or the transorbital lobotomy practice or electroshock therapy. These practices contribute to the stigma of mental institutions being places where those who suffer from mental illnesses are sent away from society. Transorbital lobotomies, which involve severing connections near the prefrontal cortex with an ice pick like instrument inserted through the eye sockets. Those were used to treat mental disorders, and now in this modern day and age are not in use anymore. And lastly, the DSM 5 is the latest edification of the Diagnostic and Statistical Manual of Mental Disorders. It is the standard classification of mental disorders used by mental health professionals in the United States. However, there have been many challenges to the legitimacy of the psychiatry, which forced profession to examine the fundamental question of what did and did not constitute mental illness. There are many issues within the DSM-5 regarding validity and reliability, overdiagnosis, and heavy reliance on cultural norms, which contribute to inherent bias within the manual. For example, homosexuality was labeled in previous editions as a mental illness. First-time drug users are lumped in with addicts, as well as for generalized anxiety disorder, it includes everyday worries, which is an overgeneralization of the diagnosis. So moving on to mental health in action, we'll go through views and trends in mental health, as well as how mental health is managed on the global stage. Who bears the burden of mental health? Poor mental health is mostly prevalent among individuals with lower incomes and of considerable financial strain, those who are exposed to poor quality housing conditions, those who are food insecure, those who have poor diets, and those who face discrimination. Around 70% of the global population do not receive treatment for mental illness. The treatment gap is even wider in low and middle income countries, where 76 to 85% of people suffering from mental disorders lack access to care. Around 1 in 5 of the world's children have a mental health condition, and about half of all mental health issues, as Aruj stated previously, begin before age 14, and most young people living in areas affected by conflict, natural disasters, and disease are especially vulnerable to mental illness and distress. Moving on to the social determinants of mental health, mental disorders have multiple determinants, and prevention needs to be a multi-pronged effort. The social gradient impacts both risk of disorder and access to services, and consequently improved outcomes. Major socioeconomic and environmental determinants for mental health are related to macro issues such as poverty, war, and inequity. Where social determinants can affect mental health can affect way of life as well. Mental illness can also impact social determinants, including homeless, school dropout, marital instability, and economics insecurity. A two-way relationship exists between mental disorders and social determinants, as poor mental health can aggravate personal choices and affect living conditions that limit opportunities. The WHO's macro strategies to improve mental health include improving nutrition, improving housing, improving access to education, reducing economic insecurity, strengthening community networks, as well as reducing the harm from addictive substances. The barriers to achieving positive mental health equity include barriers within mental health treatment, mental health service organization, as well as cultural barriers. For the barriers within mental health treatment, we chose to examine both the patient and the provider perspective. In a study exploring the barriers to mental health service utilization from the perspective of patient, it was found that these 5 items were most prevalent as the barriers for patients in seeking and receiving mental health treatment. These include lack of awareness of mental health services, scarcity of financial resources, lack of geographical accessibility, as well as the invisibility of the symptoms. From a provider perspective, the mental health clinician shortage is one of the largest barriers within mental health treatment. A huge barrier globally is that there is a large scarcity of mental health professionals. This shortage is caused by and exacerbated by many factors. Within geographical areas, rural areas often offer few to no mental health resources, and urban areas have clinics and providers whose resources are so strained that patients must wait for long periods of time before even receiving an initial intake appointment. In addition, for medical professionals pursuing mental health careers, they face little to no reimbursement from government and private insurance plan, leading to fewer doctors choosing this specialty in school. Primary care physicians are also essential in recognizing and diagnosing mental illnesses, but cannot provide psychotherapy, so they're unable to help bridge that gap. For deprioritization of mental health services, mental health had a low position on many public health agendas on both the national and international level. For the barrier of inadequacy of funding for mental health, advocates may have differing perspectives, yielding contradictory messages. This creates the view that there's a lack of consensus among experts, turning donors and policymakers off, contributing to the inadequacy of funding. For lobbying, advocates often lobby against one another to draw attention to different mental health problems, leading to fragmentation in advocacy. When even advocates agree on a problem definition, they offer too many competing views on the types of actions that they must take. The barriers within the mental health service organization include centralization of mental health resources, and they affect the treatment coverage for people with differing mental health disorders. The centralization of most mental health resources are a key barrier to progress, citing a need for resources for care needing to be geographically decentralized in order to care for communities and to be accessible and available. For psychiatric institutions, they act as a hindrance to progress due to the fact that they consume a large proportion of scarce mental health resources, have higher costs than care, tend to isolate people from their personal support systems, and are associated with undignified life conditions and human rights violations. The vested interest of mental health professionals in area of deinstitutionalization or forced relocation contribute to mental health service organization being less of a priority or contribute to that barrier, as well as the division within government systems, which may hinder decentralization. Successes in reform of policy or legislation at the national level do not necessarily translate to improvements in services in provinces or districts at the community level, especially within competition between government branches responsible for hospital services and community health, which may have hindered transferal of human and financial resources to community care. The cultural barriers for mental health include cognitive barriers, which are often culturally influenced. In some cultures, for example, there is no distinction made between physical and psychological problems because the mind and body are seen as whole. Their affective barriers, which are the willingness to report problems, may be influenced by perceptions of stigma and shame. In many minority cultures, mental illnesses may even be more stigmatized, as well as an inherent mistrust from minority cultures, can be based on the history of treatment within the psychology field. The likelihood of misdiagnosis among minorities is greater due to cultural insensitivity, as well as diagnostic instruments being standardized by using a predominantly male Caucasian sample. Mental health stigma refers to societal disapproval, or when society places shame on people who live with a mental illness or who seek help for emotional distress, such as anxiety, depression, bipolar disorder, or PTSD. The concept of mental health is viewed variably across the world. As stigma lessens in many countries in the global north, mental health and mental health disorders are often seen unfavorably in many low and middle income countries. Stigma can come from stereotypes, which are simplified or generalized beliefs or representations of entire groups of people that are often inaccurate. Lastly, another cultural barrier is value orientation barriers. For many groups, the process of psychotherapy is foreign because it requires and involves open communication around an individual's internal thoughts and emotions with someone who is not a trusted family member or a member of a respective group. This contributes to a barrier for seeking mental health treatment. All countries must contribute to help implement mental health policies to be globally effective. In low-income countries, the majority of member states reported that mental health data is compiled as a part of general statistics, but not in a specific mental health report. Reporting on mental health indicators that include both public and private sectors remain a challenge and is below 25% in all WHO regions. For mental health on the global stage, mental health treatment spending growth is likely to slow from recent trends and lag behind growth in all health spending. Mental health treatment is expected to average an annual growth of 4.6 from 2009 to 2020, compared with an all health spending of around 5.8% each year. One major reason for the slower spending growth for mental health treatment is expected to be the large number of prescription drugs used to treat mental health that will lose patent protection through 2020. Loss of patent protection will allow the entry of generic drugs with an anticipated rapid switch by consumers to these lower cost medications. In addition, few, if any, new innovative drugs are expected to enter the market. Together, these factors are predicted to slow spending growth, most notably for mental health treatment. For mental health expenditures within the United States, from all public and private sources, they were expected to total $280 billion in 2020, which is a 61% increase from $171 billion in 2009. The effects of the Affordable Care Act on mental health spending include lower prices for prescription drugs, as well as a patient diagnosed with, on average, with major depression can spend around $10,836 a year on mental health costs. Within the global context, the global economy loses about $1 trillion each year due to depression and anxiety. It is estimated that mental health conditions could cost the economy as much as $16 trillion between 2011 and 2030. $2.45 billion was allocated across all projects involving mental health on a global scale, and of that, around 16.7% was allocated to projects dedicated solely to mental health. The remaining 83% was allocated to development projects mentioning mental health but were not exclusively focused on mental health or including mental health services. In total, poor mental health was estimated to cost the world economy around $2.5 trillion per year, and poor health and reduced productivity in 2010 was a cost that was projected to rise to $6 trillion by 2030. There are more than 230 mental health organizations within the U.S. These organizations often operate at the local and community level to serve citizens who suffer from mental disorders, and often are a necessary mediator in filling gaps caused by the scarcity of mental health resources. They run the gamut of being broad and overreaching, like NAMI, which is the National Alliance on Mental Illness, or specifically focus on special interest groups such as BEAM, which is the Black and Emotional Mental Health Collective. In comparison to U.S. national mental health organizations, there are fewer organizations that operate on a global scale. Organizations such as the WHO or UN have task forces, committees, and councils specifically tasked to deal with global mental health issues. However, their scope is largely defined by budget allocation.
Thank you, Imani. My name is Nicholas Weber, and next we'll talk about the current global mental health initiatives and policies. The WHO currently has an initiative in place which seeks to ensure universal health care coverage involving access to quality and affordable care for mental health conditions in 12 priority countries to approximately 10 million more people. It will advance mental health policy, advocacy and human rights, and skilled quality interventions and services for individuals with mental health conditions. The WHO also has an action plan and specifically 4 objectives for better mental health. The first target of these objectives is for 80% of countries to have developed or update their policies or plans for mental health in line with international and regional human rights instruments. The second target includes service coverage for severe mental disorders to have been increased by 20%. And these targets will be further reinforced by service development indicators for financial resources in government health expenditure on mental health. Human resources can increase the number of mental health workers, capacity building, the number and proportion of general health care staff trained in mental health should increase. Stakeholder collaboration, number and type of formal collaborations with other departments and transdisciplinary training for service users and family or caregiver advocacy groups, and service continuity to increase the proportion of persons with severe mental disorder discharged from a mental or general hospital in the last year, and to increase their follow-up time within 1 month by community-based health services. Next, we'll discuss mental health in the context of United Nations Sustainable Development Goals. The inclusion of mental health in the United Nations SDGs in 2015 included to go beyond the 3rd Sustainable Development Goal of good health and well-being. The promotion of mental health and prevention of mental illness come through the success of many SDGs. Out of 162 responding countries, a little over half state that their mental health and policy plan contains estimates of financial or human resources needed to implement it. Of those countries who state that estimates of financial or human resources are contained in their plan, just more than half of the responding countries state that the resources have been allocated in line with indicated resource needs to enable implementation of the policy and plan. Next, implementing mental health interventions and resources. We notice discrepancies that exist across income groups, most notably that high-income countries report significantly more employment. This is 63% of responding countries, and housing support at 58% is provided by governments rather than in low-income countries, which face only 4% of reported employment. Globally, education, housing, employment, and legal support is less than 35% of the reported support provided. The future of mental health is evolving. 63% of countries surveyed reported to have at least 2 functioning mental health promotion and prevention programs, while more than 2/3 of the way towards the 2020 global target of 80%. More than 70% of responding countries in all regions report that they have at least 2 functioning programs, with the exception of countries such as Africa, where less than 50% of member states report that they have less than 2 functioning programs. In addition, funding to clinical trials will aid the investigation of various psychological, behavioral, and pharmacological approaches to suicide prevention. Next, we'll see how in 2004 the rankings for non-communicable diseases are being covered medically through therapy, giving rise to mental health disorders becoming more of a prevalence and more of a disproportionate target for health outcomes in the future. So we can look at COVID-19 and the impact it had on mental health. Basically, the economics risk factors that Anuj mentioned earlier that leads to poor mental health were exemplified in the COVID pandemic. This included social isolation, inactivity, unemployment, financial insecurity, with racial and ethnic disparities in the incidence of COVID-19 diagnosis, to name a few. This created barriers for people who are already suffering from mental illnesses and substance use disorders. With the pandemic, the statistic of 4 in 10 adults in the US have reported symptoms of anxiety or depressive disorder. This has been largely consistent, up from 1 in 10 adults who reported these symptoms before the pandemic. And then lastly, we must utilize mental health resources. We have various wellness exchange platforms here at NYU. I encourage everyone to utilize them. And I would like to thank everyone for listening to our presentation on mental health and the future for policy and intervention.